I'm Howard Schubiner. I'm an internal medicine specialist. I work at Providence Hospital, Ascension Providence in Southfield. We are inundated with the COVID-19 virus right now, and it's a really hard time at the hospital. But healthcare workers are being heroes. I don't work in the hospital myself. I have a clinic that I run there. And for the past 17 years, I've been working in the field of chronic pain and associated disorders. When I got interested in chronic pain, I learned that there's some standard pain management therapies and ways of thinking about chronic pain. And it was all very, I don't know how to say it nicely, but depressing. The approach to chronic pain, the ideas about chronic pain were that chronic pain was basically incurable, and people would have to learn how to live with it as best they can. And the treatments for chronic pain were there to try to help, palliate the pain, but people really didn't talk about curing it. And I came into chronic pain through a neuroscience background. And what I'm going to talk to you today about is the neuroscience of the brain and what we've learned in the past 10, 15 years of new research on how the brain works and how that influences chronic pain. I'm doing virtual visits now from my house and seeing patients over this past 2 weeks now. And it's so happened that I saw a woman today with trigeminal neuralgia. She started having TN about 10 years ago. She had been on 6 or 7 different medications that nothing really worked. The medications made her feel worse in some ways. And she tried ketamine infusions, lidocaine infusions. That didn't help. And she had a microvascular decompression surgery, which made her worse, unfortunately. And then she had another procedure, a rhizotomy, which helped a little bit, but she was still suffering. It was very difficult for her to carry on and work. So this has been going on for 10 years. She's a highly skilled and mom of 3, works as an engineer. And she ran across the work that I do, that I'm going to tell you about 3 months ago, 3 months ago maybe. And so I saw her for the first time today as a virtual visit. And she started using a book that I wrote called Unlearn Your Pain to see if that might help her with her painful symptoms on one side of her face and her burning mouth symptoms as well. And when I talked to her today, she said something pretty miraculous. Remember, this is the first time I've seen her. She said now she can go outside without a face mask. She has changed the pain that she's had. She's not pain-free yet, totally, but she can walk outside without having a face mask. She said she used to be covered forehead and a whole mouth and cheeks and neck and everything. But now when she encounters breeze or cold or air touching her face, she's fine. That is a huge shift after 10 years of pain. And so what I want to tell you guys, I'm going to go to my slides now. So what I want to explain to you is some of the research that's been done on the brain. And the thing is that doctor, I'm a medical doctor, But we never learned really about pain in medical school. Medicine doesn't really interface with neuroscience all that much. You'd think it would. And so I just want to show a few slides here. Can you guys see the screens now? Yeah? Good. I take that as a positive. And so I'm going to talk about the brain, and I'm going to talk about neural circuits in the brain. This slide has my email on it. If anyone has any questions that don't get addressed tonight or is interested in anything I say, please, you can feel free to email me directly. It's my private email. I've written a couple books, 3 books now on the subject. I work with some online pain programs. I get the impression that, I haven't had trigeminal neuralgia. So I can't imagine what it's like to have pain like that. But I do see people with pain every day. And in the country, there's an epidemic of chronic pain. Yesterday, I saw a guy who had migraine headaches that were so severe that he was literally bedridden for 8 years. So the amount of pain that people have to endure can be obviously, horrendous. And facial pain contributes a significant amount to the pain problems in our country, but it's dwarfed a bit by stomach pain, headaches, neck pain, and back pain. CWS is chronic widespread pain, which is another word for fibromyalgia. What do we know about TN? Well, we know that it's sporadic. It comes on for no reason. It starts most of the time without any particular physical event that happens. It is often of sudden onset. It just comes out of the blue one day. It often gets worse over time, and it can be a very severe pain, and it's often triggered by certain triggers, stimuli, such as air, cold, hot, light, sound, a variety of triggers that seem to be innocuous, like why would air, touch, just touching the face can trigger severe pain. And then oftentimes people have periods with no pain. We know that people who have trigeminal neuralgia sometimes also have migraine headaches and some other disorders. The pain can be on both sides of the face. It's usually thought to be one-sided, but it can be on both. But it's rarely on both sides at the same time. And some people, it can switch from one side of the face to the other side of the face. Most of the people with TN don't have an obvious cause that we can find. Most people don't have. I talked to a woman last week whose mom had severe facial pain, and she had a bone spur. And the doctor took out the bone spur, and she's been fine for 37 years. But most people don't have that kind of a structural disorder. Many people have a vascular compression of the nerve by an artery or vein. And so that is presumed to be the cause. But the problem with that is that many people who don't have trigeminal neuralgia also can have a vascular compression of the facial nerve on an MRI. And so that makes it confusing. When you read about TN, most people do not recommend surgery as the first line of therapy, which would seem odd. If you have appendicitis, almost everyone would recommend surgery as the first line of therapy, and the treatment is almost always effective. Surgery can certainly be effective for TN. I was hearing somebody earlier saying she'd been pain-free for 17 years. someone else said she'd been pain-free for 10 years, but then the pain came back. The research on surgery for TN suggests that it's most effective at the beginning, but for some people the effect goes away, or it's not as effective over time, which is kind of a odd kind of thing to think about if the cause was simple and the surgery was effective. It makes us think that TN is much more complicated or enigmatic or not understood as being simply pressure on the nerve that can be easily treated with a surgical procedure. The other thing we know about TN is that there are over 30 medications that are known to be effective or partially effective for it. And if you're in the medical field, you know that if there are over 30 medications that are being used to treat a condition, then you know that no single one of them is uniformly effective. And the symptoms tend to wax and wane over time. They can get better, they can get worse, they can go away, they can come back. And that is confusing. Why would pain do that? Why would something, if you have a structural cause for pain, why would it go away? If you have a structural cause for pain, why would it spread to different parts of the face, for example? The woman that I was seeing earlier, her pain started out on the left side of her face in the lower portion, and then it spread to the middle portion, and then it also spread to the upper portion. And that's a confusing thing for people to understand, and it's confusing for doctors to understand. And so it's got to be incredibly frustrating to have a condition where the deeper you go into the literature and the more carefully you look at it, the more questions you tend to have than answers. And I don't know if what I'm saying resonates with you guys, or if I'm making sense so far, or if you're kind of understanding what I'm saying is. What I'm saying is basically is that the answers that modern medicine has been able to give for people with this enigmatic and horrible disorder really have not been all that great. I guess that's basically what I'm saying. But as we talk about what I'm going to switch over to now, as we talk about the brain and how the brain works, I think you'll see that some of the features of TN frequently fit with the type of model that I'm talking about and for how I treat my patients. So predictive coding is how the brain works. What that means is the brain works like a computer. It gets data in from your whole life and from this moment, and then it takes that data and it codes, it creates something. It turns out that our brains create what we see, what we hear, and what we feel. This is an extremely revolutionary concept to understand about how the brain works. I'm sure many of you have seen this drawing before. Are you with me? Can you see a more experienced woman, or do you see a younger woman? Or do you see both? It's hard for me to see all of you. Where's my thing? Here we go. I can see some of you. But do you see the more experienced woman looking sideways with a large chin, large nose kind of thing? You can see her eye. And then if you look to the left a little more, you see a younger woman with her face pointing away from you. Well, those are two images. And it turns out that our brain constructs what we see. what I'd ask you to do is see if you can see both of those images at the same time. Usually people can't, but usually they can see one image and then shift their focus to see the other image. Are you with me? And if you can shift your focus from one image to the other, what's happening is that your brain is literally creating the image that you see moment by moment. And image is a neural circuit. It's a neural circuit. We have a neural circuit for seeing robins versus a different neural circuit for seeing cardinals versus a different neural circuit for seeing crocuses and a different neural circuit for seeing daffodils. And neural circuits are how we see. Neural circuits are also how we feel. This is a guy who I met, who was a friend of mine, who shot a nail in his hand several years ago. He was at a construction site. And does that look painful to you, I would guess? This guy had zero pain. He had no pain at all. How can that be that someone could have an injury but have no pain? It turns out our brain is responsible for turning pain on or turning pain off. If you're running to catch a deer 10,000 years ago and you break an ankle, do you want pain? The answer is yes, you definitely want pain, because if you don't get pain, you'll continue running on a broken ankle and you will ruin that ankle and you'll never run again. If you're running from a lion, being chased by a lion, and you break an ankle, now do you want pain? The answer would be no, because you will die. You'll get eaten by the lion. And so it turns out when you touch a hot stove, it's not your finger causing pain, it's the brain. All pain is caused by the brain activating something we call the danger alarm mechanism, and that's the cause of all pain. Now, certainly when you touch a hot stove, it's likely you will get pain because the signals that go to the brain activate the danger signal and your brain turns on pain. Why did this guy have no pain? Probably, we don't know, but probably because he was alone. His brain had to choose between having severe pain and being alone, or him driving to the hospital, and that's what his brain chose. So he had no pain, even though he had a severe injury. This is a guy who jumped off the scaffolding onto a nail at a construction site. The nail, and if you can see it, the nail went all the way through his boot. He has severe pain. They rushed him to the hospital. They gave him IV pain medication when he got there. And what happened is they took the nail out, they took his boot off, and it turned out he had zero injury. The nail had passed precisely between his two toes. And he had no injury at all, but he had severe pain. Was his pain real? Absolutely, because all pain is real. And all pain is triggered by the brain. In this case, the brain was mistaken about if there actually was a physical injury, but the brain turned on pain so he would get to the hospital just in case. It turns out that stress and emotions in research studies activate the exact same parts of the brain as does a physical injury. This guy had the stress of seeing a nail go all the way through his boot, and that stress activated his brain to turn on severe pain. This is a completely different way of looking at pain. The third story I'll tell, and last story I'll tell about pain, this guy was a friend of mine who was in the Vietnam War as a young man, and one day his company got ambushed, and he had a shrapnel wound to his leg and had a lot of pain and got medevaced out. He came home, his injuries healed, and his brain turned off the pain, and he was fine, pain-free. 20 years later, he was walking down the street, and all of a sudden, he heard the sound of a helicopter coming up from behind him, and at that moment, he got the same pain in his leg that he had had 20 years earlier. How did that happen? his brain had learned pain as a neural circuit in his brain. What's a neural circuit? A neural circuit is how we know how to ride a bike. A neural circuit is how we sign our name, how we walk, how we talk, how we smile, how we gesture, how we laugh. Those are all neural circuits in our brain that have been learned. And his brain, and that neural circuit for pain was triggered by the helicopter 20 years later to cause the same pain. A trigger is something that causes the brain to activate pain. What is the feeling of touch to one's face, or the feeling of having air or cold brush onto one's face that triggers severe pain? That's a trigger. It's something that triggers the brain to activate pain. Am I making any sense to you guys? So all pain is real. There's no such thing as fake pain or imaginary pain. All pain is generated by the brain. And pain can be triggered in the presence of tissue damage or in the absence of tissue damage. And the pain that's triggered is the same. The pain of that guy with the nail in his boot was as severe as any pain that could ever be. Migraine headaches is an example of pain that's triggered by neural circuits in the brain. And obviously, the pain of migraine headaches can be extremely horrendous and severe, like the guy I talked about earlier who was bedridden for 8 years with migraine pain. This guy, by the way, now is fine. He's pain-free. So one would ask, what proportion of people with chronic pain in this country have structural problems versus the proportion of people who have neural circuit type problems that are causing pain? A structural problem would be, so if someone has headache and they have a brain tumor, that would be a structural problem. If they have headache and they have a tooth abscess or a sinus infection or an ear infection or a bleed in their brain or vasculitis in their brain, an autoimmune condition, those are all causes of structural head pain. But when you take those out from the people with chronic headache pain, the vast majority of people do not have a structural problem for their pain. Fibromyalgia or chronic widespread pain is a similar situation where you've taken out the people who have structural causes. Irritable bowel syndrome with abdominal pain is similar. Pelvic pain syndromes are similar. And you might be surprised to know that most people with chronic neck and back pain do not actually have a structural cause for their pain. Now, some of you are probably thinking, Dr. Schubiner is really a wacko. Dr. Schubiner must be nuts, because what is he talking about? It turns out that people who have chronic back pain, their chronic back pain is usually attributed to degenerative disc disease or bulging discs or other things like that. And it turns out that the vast majority of people who have no pain have degenerative discs and bulging discs with no pain at all, which is interesting because it's a little bit similar to the idea that people who don't have TN can have MRIs which show compression of the facial nerve by an artery or a vein. And so what I do in my practice is I am extremely careful and cautious to try to figure out what is the cause of an individual's pain. Is it a structural problem or is it a neural circuit problem? The pain can be the same, but if you don't have the diagnosis accurately, then the model that you're using is going to be different. From my point of view, if someone has structural pain like joint damage, autoimmune disease, cancer pain, they need a coping with pain model. But from my point of view, if you have a neural circuit pain condition, then a curing model is more appropriate, because a curing model means that we can work to reverse the neural circuits in the brain, just like that guy with migraine headaches did, and just like this woman I was telling you about with TN is starting to do now. So as I mentioned, structural causes are structural causes. I don't treat people with structural causes for pain. The second step is to look and carefully understand what I call to rule in a neural circuit disorder. And how I do that is by what I call these 4 steps. The first step is to look at the characteristics of the pain to see if they fit the model for neural circuit pain. And these are some of the characteristics that tend to go with neural circuit pain. For example, begins without a physical precipitation, comes out of the blue. The pain can be on can persist after an injury is healed. It can be in a distribution pattern that's symmetric, such as both sides of the face or both sides of the back or neck. It can occur on one whole side of the body, one whole half of the face. It can spread over time. That's common with TN. It can have the quality of tingling, electric, burning, numb, hot, or cold. And this is common with neural circuit pain to have those kinds of sensations, which are, of course, common with trigeminal neuralgia. The symptoms of neural circuit pain are often what we call inconsistent. They may shift around. Sometimes you may notice that the pain may be in one part of the face, and other times it might be in another part of the face. That's a shifting location. Structural problems the pain doesn't tend to shift from one part of the body to another part of the body. If your arm is broken, the pain doesn't shift to a different part of the body. The pain can vary during the day, sometimes drastically. It can turn on and off. Neural circuit pain often does that. It can occur when you even start thinking about it. The pain can be worse when stress occurs. And it can go away when you're engaged in distracting or joyful activities. And the last thing is triggered. And this is what we've talked about already, whereas pain that can be triggered by food, smells, light, sound, weather, computer screens, wind, cold, light touch. To me, those are signs of neural circuit pain because the air that's touching the face is not actually touching the nerve, it's touching the skin. And the skin is connected to the brain. And it's my view that the triggering phenomenon, like the helicopter that I talked about, is a sign of the brain triggering neural circuit and, of course, very real and often severe pain. Symptoms can be triggered even by imagining sometimes the trigger. And I'm going to describe a patient with TN who had that in just a minute. So when people talk about the brain creating pain, oftentimes people confuse brain created pain with the notion that the pain is all in the head or not real. Anyone who says that anyone's pain is all in their head is either ignorant or cruel or both. Because that implies that the pain is imaginary, not real, that it's someone's fault, that they're crazy, they're mentally ill. And none of that is true. This is very important to understand. And the woman that I talked to today, this morning I was telling you about, who has started to work on this on her own before even seeing me, she said that the most important thing that made her agree to use the model that I'm using and to use the book that I wrote was that she understood that I was saying that the pain is real. And she said, without that, I wouldn't have given your model a second thought. So I just want to make sure that you guys understand where I'm coming from on that issue. So this model of how we help people to reverse the neural circuits in the brain is to understand that there's a danger signal in the brain. And this danger signal is like a smoke alarm. When it's triggered, it makes a loud sound. In our brain, the smoke alarm makes a loud sound. In our brain, it makes pain. It can also, the danger signal can also cause other symptoms such as anxiety, depression, fatigue, insomnia. The symptoms of pain particularly are often so severe that they cause a tremendous fear, a tremendous worry about the pain, a tremendous focus on the pain. Who wouldn't have that? Everyone would. It's normal to have that. And it turns out that the fear and the worry and the focus actually tend to drive the danger signal to create more pain. And this is frequently why pain worsens and spreads, chronic pain worsens and spreads over time. Stress and emotional issues can activate the danger signal. The woman that I saw this morning, when her TN, oftentimes when TN starts, people may not have any particular stress in their life at all that they happen to recognize. In this case, she had a tremendous amount of stress in her life at the time when the pain started. The model of treatment, the main model of treatment that we use, we call pain reprocessing therapy, which is kind of a code word for helping to rewire the neural circuits in the brain. And just to point out that we did a study recently on people with chronic back pain who had, there's a train going by, sorry about that. People who had chronic back pain for an average of 10 years of back pain. And we randomized them to 3 different treatments. And we found that 95% of the people we randomized did not have disease in their back. They were neural circuit pain patients, in my opinion. And 75% of them were pain-free in 1 month with this pain reprocessing treatment. And the pain scores stayed down for 6 months. Now we have 1-year data on these people. And this is with no medication, no surgery. These are just with the methods that I use to help people retrain the circuits in their brain. This therapy can be extremely effective, but it's not always effective. It's effective when the people who have the problem get that they understand that I understand that their symptoms are real, not imaginary. But they also need to understand that their symptoms are caused by neural circuits and they're not actually harming them. That their brain has been sensitized and their brain is activating these symptoms that can be reversed. And everyone has, to some degree or another, brain that activates symptoms. I certainly have had neck pain for years. That was due to my brain activating pain, back pain that was due to my brain activating pain, and a whole variety of things like that. So this is really in part a normal condition of humanity, and this is not anyone's fault. So let me just wind up by telling you about this other woman that I saw, young woman. She had facial pain for 4 years. It began, it was a horrible situation. Her ex-husband was really on drugs and doing crazy things, and he ambushed her one day and he punched her in the mouth and dislocated her jaw. Her jaw was reduced in the emergency room and she had no pain after that. The pain in her face began 6 months later. So was that pain due to the injury, or was that pain due to something else? Well, she was diagnosed with trigeminal neuralgia. She had burning, stinging, shooting, severe pains. It was worse with cold, worse with swallowing, worse with loud sounds, bright lights. When she was frightened, it got worse. She had a whole variety of treatments, as you can imagine, injections, dental work, Botox, nerve blocks, medications. She would wear a mask all winter and she would have a panic attack by having to go out in the cold because the pain would be so severe. This was on the right side of her face. Over time, the pain spread to the left side of her face as well. And she had surgery. Her doctor said this was a clear-cut case, that she would be better because it was clear that the nerve was being compressed. And the pain went away for 2 months. And then it came back. And then she started getting migraine headaches on top of it. And the pain worsened. And as I mentioned, it spread to the other side of her face. When I saw her for the first visit, I explained all of this to her, and it made sense to her. What I'm saying may not make sense to you, but it made sense to her. And she began to understand that the pain was actually being caused by her brain and not by a disease process in her face. And I asked her to do a couple, exercises. And one of the exercises I had her do was to sit and to do a little meditation and watch the sensations in her face and just see what happens. And as she watched the sensations in her face, they started to move. At one point, the sensations were more down by the ear, and then they moved up closer to her mouth. And then they shifted to the other side. And I said, see, when the pain shifts like that, it's a sign that some neural circuits are turning on and other neural circuits are turning off. And that made her say, oh yeah, I can see that. That makes sense to me. I get it. And then I asked her, and because she had such fear of cold, I got a ice pack out of the freezer and I set it on the desk in front of her. It wasn't touching her, but it was there, sitting on the desk. And I asked her to close her eyes and imagine putting that ice pack to her face. And as she did that, she got pain in her face. And why was that? It wasn't from the cold. It was from the idea of the cold. It was from the fear of the cold that had built up over those last 4 years of having severe facial pain related to a variety of stimuli, but one of them was cold. And then I explained, well, this is what's going on. And I said, the pain is not due to the cold. And she said, I know, the pain is due to the fear of the cold. And I said, yes, that's exactly right. And then I asked her to close her eyes again and imagine taking this ice pack and putting it to her face once again, knowing that the problem wasn't in her face. And she imagined putting the ice pack to her face this time, and there was no pain when she imagined that. And then I asked her if she would be willing to take the ice pack and actually touch it to her face. This is something she would never do in a million years. But she said, okay. And she took the ice pack and she calmed herself and she touched the ice pack to her face and there was no pain. That neural circuit had shifted and changed in a very short time. And she was shocked and amazed. She called her boyfriend and she asked him, what would you do if I told you I'm going to put this ice pack to my face? And he said, if you do that, I will take you to urgent care. So this is an example of the kind of understanding that what I would like to think of as advanced neuroscience or emerging neuroscience has about the role of the brain in pain. The other woman that I told you about, who I saw for the first time today, I was asking her about this, and she said, if you had, this has been 10 years for her. She said, if you had told me that my brain was causing my pain 5 years ago or 7 years ago, I wouldn't have believed you. I would not have been interested in your treatment at all. But now, after 10 years, and have been through what I've been through, and nothing has worked, I'm interested in it. I want to try it. So this model is not for everybody. I don't claim to think that it is for everybody, but I do evaluate people and I help them distinguish between what I call nociceptive pain or structural body-based pain and central or brain-based pain. And my view is that pain is an interpretation made by the brain and pain is commonly is generated by neural circuits, but the pain is pain commonly occurs in the absence of physical injury. This is obviously a revolutionary, and some may say a crazy or irresponsible statement to make. But after working in this field for 17 years, I'm convinced that it's true. And we have research data to show that we can make a difference. So there's a lot of resources that are available online. My website is the fourth one down, Unlearn Your Pain. There's an app for this called the Curable app that I'm also a sponsor of. There are some books about this model of healings. Some of them I've written, and some of them were written by Dr. Sarno, who was a mentor and teacher to me. There are some other doctors who've written books. There's also some books for professionals on how to do this work that I've also been involved in. There's even some movies about this. There's a movie called All the Rage about Dr. Sarno. There's a movie that was filmed in Detroit about my work, and that movie is now available online. And there's another movie in the works about the back pain study that I showed you earlier. So I think my time is up. I've used exactly 45 minutes, which I said I would do. And I'd like to open it up to any questions that you might have. You can ask your questions by typing them in on the chat. If you go to the lower part of your screen, there's a little icon that says chat. And if you click on that, on the right side of your screen, there's a chat box, and you can type in a message and hit enter, and everyone can see it. You can type a message just for anyone. You can type a private message in there if you want to send a private message to Tim and Donna, or to Peter, the host, or to each other, and say what an idiot this doctor is. Anything you want. So if you have any questions, I'd be happy to try to entertain them. I see, while I'm waiting, I see a couple things on the chat. Lynn asked, where can I view the movie? And I will send a link to view the movie to Peter and Tim. It's not free at the moment. Everyone thinks everything should be free, of course, nowadays. It just came out like last month, but you can see it for, I think it's $20. The next question is this neuroplasticity? Yes, this is the definition of neuroplasticity. Neuroplasticity is exactly what I've been talking about. It's just another word for it. Neuroplasticity is a situation where the brain, it means the brain changes all the time. Every time you learn a new fact, your brain changes. If you learn how to play the violin, your brain changes. If you learn a new language, your brain changes. If you learn pain, your brain changes. All those things are neuroplasticity. The good thing about neuroplasticity is that the brain can change for the better. Another question here is, you talked about irritable bowel, IBS, as irritable bowel syndrome as one of the conditions. And the question is, what about IBS involving a change in bowel consistency more than pain? Yeah, I had irritable bowel syndrome when I started my internship. I had diarrhea for 6 months. It turned out I was scared of being a doctor. Scared shitless is one way to put it. So yeah, the brain can change, can make constipation or diarrhea. And it does that through the autonomic nervous system. The brain controls the autonomic nervous system. The autonomic nervous system controls the blood vessels, makes the blood vessels dilate or constrict, makes the bowel go faster or slower, makes the bladder contract or not contract. So that causes blood pressures to rise or fall. So the autonomic nervous system can cause all those sort of things. Peter, you should unmute everybody. Anybody can ask a question.
We were having trouble putting in the question. Does insurance cover your practice, Dr. Hi, Yoko.
Does
Lynn, you see Yoko?
Just a second, I'm trying to help somebody.
How are you, Yoko?
Hi. Hi. How are you?
I'm good. How are you?
Yeah. Nice to see you again.
He's calling in from Japan.
Oh,
Yeah.
really? Oh, wow. That's amazing.
Yes, from Japan.
It's an honor. Thank you so much.
Yeah, thank you too.
You're
So-
beautiful as ever, Yoko.
Okay. Yes.
Yeah.
Yeah. How are you? How are you, Tim?
Good,
This
good.
isn't
Mm-hmm.
Lynn is there someplace.
Yeah, here's my little fluffy hair.
Oh,
I'm just
Lynn,
kidding.
yeah.
Hi, Yoko.
Hi.
Good to see you.
Yeah, good to see you too.
Doctor, does insurance cover your practice?
I'm sorry. I said, yeah, I heard your question. I said, yes, it does.
That's
Okay.
awesome.
You might not have heard me. I just
Yeah.
gave one word answer. I said yes, but maybe it wasn't clear enough.
That's
Didn't hear
great.
that.
Yeah.
We had a great turnout, Dr. Schubiner.
a lot more than you see.
Yeah, a lot, at least 30, I think, as I count up. So thank you so much for your information.
My pleasure. Yeah, if anyone has other questions, you can forward them to me through Tim or Peter. And if you want to reach me, you certainly can,
Yeah, that was very, very educational.
You really interested in psychology
Yeah, thank
and psychology and psychiatry.
and neuroscience.
Yeah, I'm looking forward to seeing the movie. We've got a captive audience now.
I said it's like what is it?
Oh, is it neuroscience?
Neuroscience. Yeah.
So after the
Oh, thank you.
evaluation,
Okay, all set. Anything else? I'll take my leave and thank you all very much. I appreciate the opportunity to speak with you guys.
Thank you, Dr. Schubiner.
Thank
You're
you.
wonderful.
Thank
We appreciate
you.
your
Thank you
support.
so much.
Take care. Bye-bye.
Someone else came on with a question.
And, yeah.
Somebody else was popping up.
No, not.
I was wondering after the evaluation, what does the treatment involve?
Oh, he left. You can email him though.
Okay.
Yeah. The book Unlearn Your Pain is set up like a workbook. It's very informative. He gave a copy to us and I started working through it. I didn't realize how much like grief there was that I held on to. Like grief about dragging my family through all of this and like how it impacts your career and your livelihood and things like that. Like it's really tough. Yeah.
I'm on a call with my transgeminal neuralgia group.
Yeah, we will send out Dr. Schubiner's email. It's hschubiner@gmail.com, I believe.
Well, yeah, Unlearn Your Pain is the book, right?
Right, right.
And then the movie you said you were gonna, how was that gonna be accessible?
He's going to send us the link.
Okay.
So we'll send it out. So if you guys wouldn't mind putting in your emails in the chat section, then we will be able to forward the link and Dr. Schubiner's contact information.
His email is hschubiner@gmail, like Lynn said. hschubiner@gmail.com.
That's when I learned that Humira can help get and keep UC under control when other medications have
That's great.
She controlled the class.
Oh, good. Your chiropractor referred you to read the book. Good. Has it helped you?
And
That's great. That's fantastic. We're glad it's helping. I know the fear of the pain is a component of it for sure.
We can't hear the other person talking, Lynn. Are we doing something wrong?
A majority of adults who took those
I don't think so. No, I was just reading the comments.
Oh, sorry.
Oh,
We couldn't use the question portion for some reason.
I wonder if this helps all kind of pain.
Yeah, I'm sure it does. Because he was talking about, headaches, back pain, IBS.
Any non-structural, right? Is what I understood.
Right.
He was very interesting.
Yeah.
was. Very. Okay. It reminds me of, what is it, when they try and put you to sleep and,
Right.
and if you don't believe in that, I don't think anybody can put you to sleep,
Right.
It requires a great deal of self-sacrificing of your disbeliefs, abandoning them, and taking on his philosophy. So
Barb Blank said hypnosis. Right.
yeah.
Yeah.
Lynn,
Yes, Linda.
I had done probably 2.5 months of therapy that he describes like that before my craniotomy, and it did not help. But I don't know, maybe it was just so severe and I needed to be decompressed, but that too was not working for me at a pain clinic. So I'm well versed in this topic, and they did extensive education at the pain clinic, but for me it did not work. Yeah,
It doesn't work for everybody. That's for sure.
no.
Do we let other people introduce themselves, Lynn? I think Andy's on from Orange County.
Someone mentioned another good book is The Great Pain Deception. That's good to know. Yeah.
Maybe.
Somebody mentioned hypnosis. Has that been beneficial? And where did you get that done, if it was?
No, I just said it's much like that.
She was just commenting about it. We haven't used it.
Okay, gotcha.
I tried it on her, but it didn't work.
Love you.
I tried some integrative medicine at St. John's at their cancer center. This is before I ended up with breast cancer, and they did some sort of medical hypnosis, and it was more like meditation. And what was interesting to me is the cold is a real big trigger for my face, and they were talking about like being on a warm sunny beach, and how the heat from the sun really did make me feel less pain. Like I don't think I could stay in that mind space, but it was interesting if you can like relax into it. And
It's like mind over matter.
yeah, guided imagery. You're right. Yeah,
You see Dr. Casey's online.
I saw that. Thank you for joining us, Dr. Casey.
Not a problem.
That's awesome. What are your thoughts on this?
Oh, I think it's premature to summarize a 45-minute talk in 2 minutes, but
Yeah.
Certainly the concept that pain, you have to have a brain to have pain. You don't have pain in a nerve. You don't have pain in a amputated foot. You don't have pain in a gunshot wound. You have pain because your brain makes several decisions. There are 4 different areas that we're aware of, and one evaluates the neural input as to the extent and level of damage, and has as far as we can tell, a preconditioned
area. The reason I say it this way is that we've actually been looking at both animal and now human models in the military that a certain amount of hypoxia makes more pain more tolerable. And that's also true
Really?
for strokes. Yeah, it protects the brain and seems to help with strokes. So the point is that this is the one area. Then the second area of the brain makes a decision about, in the context of what else is happening, how serious is the threat. So if, only because I've seen the research, if you look at soldiers who were shot on the battlefield through the calf or upper arm, compared to if they're shot in their hometown or, say in training, their ability to move forward and execute the mission as it's defined is quite different. And so that seems to be the preconditioning motion, much the same as the hypoxemia for stroke. So there's some similarities there. The third has to do with an area of the brain called the insula, which has to make what's called a threat decision. And the insula seems to be intimately related to how serious is this current stimulus that we have received from these integrated circuits to the survival of the organism. And I know you're well aware of the books I've written. One of them is The Molecular Basis of Pain. It's 857 pages. It's quite good if you have trouble with insomnia, because you'll be asleep. What we talked about in the foreword is that pain is teleologically fundamental to the survival of an organism. We cannot not exist with a pain system. So the question is always, well, what's the pain system doing on any given day? Well, it's always analyzing threats. It's deciding to what degree is this threat an issue and what should I do about it? So if we come back to some of the things that Dr. Schubiner talked about, yes, if you, and this would be true for every single person who's listening, if you remember the day that you reached into the microwave to pick up the coffee cup that was too hot, right now you can feel that burn on your fingers. So that's correct. That's a neural circuit. Your mind has no trouble recalling, wow, that really hurt, and I had to set the cup back down, maybe you dropped it or whatever. And that's learning. That's pain learning. We learn, stepping on tacks is not good. Backing into sharp objects is not good. But there are things that you do purposely, and this warns you about them. So when you grab a hot bowl the second time out of a microwave, I use that because it's so common to people. Almost immediately, their mind says, oh, wait a minute, that's going to be too hot. Because they did that once before with a hot coffee cup and knew they had to back away. And that's a neural circuit, no argument. You can't defeat that circuit. There is no way to overcome in the brain's hierarchy that you could hold on to the bowl, because the brain's already rated that at the insula level that this will cause tissue damage, which is ultimately what the pain system exists for. Will this cause damage to the organism or the tissues such that it will threaten our existence? So many of the things that we have, whether it's phantom limb pain, an amputated foot, anesthesia dolorosa in a fifth nerve that's been abused, or standard trigeminal neuralgia, we have to differentiate between that which is due to a driven situation, cross compression of a nerve is the older theory, or genetic sense that it's gene driven. It's gene driven by intolerance to pulsatility. It's no longer just vessel compression. And therefore it gets embedded as a memory, or is it something else? And the IBS is a great example. And his example in medical school was perfect. You start medical school, you're panic stricken about the fact that you may be thrust into the front lines, which, you know, if we go down to Detroit receiving today, there are medical students who finished early who are suddenly in the front lines, and they're panic stricken. They're afraid they're going to kill people, and they will. And it may not be their fault, but that doesn't change their sense of panic. So they have fast heartbeats, and they have sweating, and they have chest pain, and some of them are going to get bowel symptoms. All real. And I agree with him that no one should ever tell a patient who has pain, I'm sorry, it's in your head. Yes, is the answer. It's in my head. It's in my brain. It's in my head. Luckily, my brain is in my head and not sitting on a table somewhere. That has to be the comeback that you need to push out to your support group. That when someone says it's in your head, they agree readily with the doctor saying, that's exactly right. That's where my brain is. And whisper to themselves that may not be where his or her brain is. Certainly where their brain is.
Yeah, and their brain.
Right on.
Right on. No argument about that. And so people need to understand that not the word imaginary is always so dangerous. And neural circuits, we're still working on them. We can sometimes see them, but not other times. And the next millennia of doctors are all going to be, unfortunately, test oriented. Show me a picture. Show me this. I have to see a vessel on MRI in our particular case, and that's incorrect. You know, PJ in heaven and his disciples here on earth, we know full well that that's incorrect. But it's never going to go away as this idea that if I can't see it, therefore it isn't real. And the patients who are suffering need to say, it is real. It is changing my life. And whether it's in my head alone or in my head and somewhere else. And I'd always tell them, use the example of the amputated leg. Most doctors, no matter what their age, get that. That if someone says, I know my leg's cut off from diabetes, trauma, whatever, but I can still feel my foot. Everybody gets that. Well, this is the same. This is not at all different. So following Gamma knife, following decompression, following any number of procedures, if the nerve is continuing to somehow genetically activate the system, they're going to have pain. So I think in that respect, he's right that the concept that you can, I don't like the term unlearn because that isn't possible, only because, as I said, pain is fundamentally important to the survival of the organism. You cannot survive without a pain system because you'll hurt yourself and not know it, etc. But can you change it? Well, sure. He alluded to that. Joyful experiences, distracting experiences, and everyone's had that. Everyone's had something where I have to go on so-and-so's wedding and the whole day is good. The problem is people often tell me, well, I had to go to so-and-so's wedding and I only made it halfway through. Well, family gatherings with a number of families sometimes isn't as fulfilling as we would all like. So it can get you halfway through and then it sets it off. So those are my thoughts. Excellent summary on his part. I would just counter that everybody's in their own mind, and their own mind is where they need to be. And they need to make sure when they're talking to physicians, nurse practitioners, and I would really emphasize a second. I think, sadly, the nurse practitioners, both in neurology, to an extent in neurosurgery, and certainly in internal medicine, have really stepped to the fore. They listen. They want to hear what the patient has to say. They don't keep interrupting to, make their points, which all of you who've been to a neurologist know that you get about 2 sentences in and then you get a question. And you get about 2 more sentences in and you get another question. And from the questions, by then he's already made up his or her, made up their mind, and you're done. That's not the nurse practitioners, to their credit. It really isn't. So I almost have said we need to push out a whole generation of nurse practitioners who want to listen. That's all they want to do. They just want to hear, what does the patient have to say, and what's the impact of what they just had to say. 2 things that nurses do, and not because I happen to be married to one who's in Florida hiding out from the bug, but because they know that that's what they were trained to do.
Yeah.
That's what they've done their whole professional existence, and it's kind of why they went into it. Oh.
Dr. Casey, one of the things you've said to help pain patients was to have something to look forward to. And I thought that was really helpful, and because you produce the endorphins just thinking about something good coming down the road. Now that we're quarantined and facing all this, do you have any there's not much to look forward to. What suggestions?
Well, I disagree. I think, I happen to believe in God. I think he's up there or down there or over there or wherever he might be. And he has several different names. He's Yahweh, he's Allah, he's this, he's that. We all worldwide in our religion systems have some sort of being that we sort of say, okay, he's the king. There's too many of us. The planet passed its carrying capacity. And maybe this is the only way he has of getting the numbers back into perspective. And I don't pretend to know that. And if I'm one of those people, I'm COVID positive. I tested positive the other day.
I'm sorry to hear that.
Well, I see too many patients. I intubated
Right.
people to this. My wife goes and says, well, why'd you go in and see these patients? Well, what do you tell the person with the broken neck or the big hemorrhage? Sorry, try to have this at a more convenient time. And it just doesn't work. So instead you say, hey, whatever he's going to do, he's going to do. Maybe he's telling me to get ready. Maybe he isn't. So if you talk about hope, it's going to get better, unlike Carrot Top, who doesn't really have a clue. That's that fellow in Washington. I'm trying to think of his name. Dump. Not those words. I don't happen to remember it. In any case, but as a medical community, there are people who are literally tirelessly working, not, in all fairness, not so much for this round. They're worried about the next round.
Yeah.
They're going to be ready. I think they're going to be ready to go. I think we've learned a lot. But, are we going to go back to, remember, the flu usually managed to bump off a fair number of us every year worldwide, and we kind of got used to it. We put it in the background. We just figured, well, flu gets some people. Smallpox used to get people. Polio used to get people. This will be one more of those challenges that brain power will either come or overcome. Yeah. So I don't worry about it that way. I just say we can't give up on each other, and we certainly can't start fighting. We certainly can't start, hoarding, where people are stealing things from others, and that's the worst. But we don't see that. What you see instead is people giving meals to folks that are working. I mean,
right.
We're all trying to do something for the folks that are out there.
Can we do anything for you, Dr.
The other day, well, can I give you some money since you're here? No, I said, I have a wife who loves me, and I have a daughter who I moved in here because she has no staff. I'm set. I have what I need. And PJ was kind enough to give me a career and something to do for people. And I'm not worried about anything else. Every day the sun comes up, I usually say, okay, good. Good to see the sun again.
God bless you, Dr. Casey.
That's what the face paint patients need to say. You know what? Somewhere, either it's Ray Sakula in Pittsburgh or the fellows down at Musics at Keller, or, you know, even to be fair, Dr. Burchell in Oregon, he's very negative about the idea of vessel compression. But I like that. As a scientist, I'd be like, perfect. Somebody takes something that we've kind of held for 20 years, and we thought it worked, but it didn't work for everybody. So it's really good to have somebody smart step in and say, okay, I'm going to challenge this. I want to see if it's really true, and what else can we do? Great. Absolutely great.
Yeah.
That's a smart guy getting other smart people to say, well, let's look at this again. Maybe we got a little too, settled in this concept. Mm-hmm. And that's perfect. It's exactly what you want. Never give up. That's the message I would have to face pain patients. Don't give up on us, and don't give up on each other. And that's what support groups do. They say, we didn't hear anything new this week, but we're still going to chit-chat. We're still going to get folks to talk to us. We're still going to just give each other, nowadays, electronic hugs. I don't think they're as nice as a hug that you get from my wife, but I've tried to talk to them.
Oh, well, thank you so much, Dr. Casey. Please take good care of yourself.
Thank you.
You're in our prayers.
Please say hello to your daughter, Dr.
As you guys are for me. I mean, I am always looking that somebody that we train is sitting there going, wait a minute, this will work, and they'll fix it.
Yeah.
I disagree with Mike. I don't think we're going to cure something that's related, but can we control it better? Oh, yeah, absolutely.
Yeah.
Just requires the smart.
Mm-hmm.
And there are guys younger than me who have much, much more smarts. And that's what I love, that they're challenged. They feel like, I gotta address this. I gotta do something. It's good. That's what we do.
Yeah, you've done a fine job, Dr. Casey. Stimulated a lot of minds.
Hope so.
Yeah, absolutely.
So glad I had the chance to visit with you guys. This is a good idea. I've seen your things about the space and attendance. We did this in Minnesota, not nearly as successfully as you just did it. This may be the better solution.
Yeah, I think you're right. It's weatherproof, virus-proof.
Weatherproof, traffic-proof.
Yeah, exactly. I mean, it's just easier to go.
Distance.
Yes. Yeah, we've got Yoko here. Did you get to see Yoko from Japan, Hassan?
Yes, I did.
Yeah, that's fantastic. Yeah,
I mean,
wonderful.
it allows folks who literally couldn't have been there otherwise
Right.
to be there.
Well, it means a lot for us to have you and Dr. Schubiner in tonight. Thank you so much.
Not a problem. Keep me in the loop.
Okay, sure will. Our prayers are with you. Stay.
Take care. Have a nice night.
You too. Bye.
Go to your daughter, Dr. Casey.
I will tell her. She's expecting dinner. She's over my shoulder. Dad.
Can she come on?
Lucky you.
Can she come on to say hello?
He is dipped out.
Was that not nice, huh?
Yeah.
Extra prayers for Dr. Casey.
Yeah.
Darn it.
Yeah.
I have to leave now, the meeting, so I'm going to sign off.
Yes. Okay. Thanks for joining us,
I
Nadine.
hope everybody stays well.
Oh, you guys too.
Safe.
Have a good evening, Nadine.
Okay.
Bye. Nice meeting you. Good luck.
Bye.
to you.
Nice meeting you.
Take
Bye,
care,
Nadine.
everyone. Bye-bye.
Thanks, Pete.
Bye.
Thanks, Pete. And Lynn,
Thank
for
you,
all your
Pete.
effort.
Yep.
Thank you.
Thank you, everybody.
Yeah.
For coordinating everything. Thank you.
Thank you all.
Thank you so much.
Thank you so
Okay.
much. Yes.
So I'm ending it, I take it?
Yeah.
Yep.
Yes.
Thank
All
you,
right.
Pete.
You guys are awesome. Take care. Bye-bye.
That went really great. Thanks.